Hi, this is ELMER 2 at the University of Illinois at Chicago, Department of Ophthalmology and Visual Sciences in Chicago, Illinois. I was asked to put together our experiences with the current pandemic and how this has affected our operations here in Chicago. Um, and this is just a little slideshow that I put together as we've been very active in trying to create processes on the fly as different circumstances arise. I think it's important really to look at the background of COVID-19. It is a very unique infection and virus that's causing the current pandemic. As far as providing rationale for some of the changes that we've made to our clinic operations. As you all know, the coronavirus originated in Wuhan, Hubei province in China. It was recognized apparently in early December, if not earlier, as causing a SARS-like syndrome in Wuhan. For background, R naught defines communicable disease's rate of infecting other contacts. So basically, for every patient who has it, if they infect two other patients, that would be an R naught of 2. If it's 1 or less, the infection will eventually die out if nothing causes its infectivity to become worse. It was initially reported, I believe, in mid-January to the world. Its initial R naught was reported as 0, meaning that there was no evidence of human-to-human transmission. Within a week or two, human-to-human transmission was then reported. The initial estimates grossly were that the R naught was about 2 to 3. To give you some reference, the R naught for seasonal flu is about 1.3. And for SARS, it was estimated to be between 2 and 3, although in Korea, studies show that within healthcare workers, it was significantly higher. A recent analysis within the last week or so from the Los Alamos facility in the US, looking at some of the data from Wuhan peripherally, felt that the R naught was more realistically estimated to be somewhere between 4.4 to 6.6. And to give you reference for that, the R naught for smallpox, polio, is somewhere between 5 to 7. And these numbers are really all based on limited surveillance testing, as we know that there are probably a significant burden of asymptomatic diseases or disease states that occur with COVID-19. Helping further explain these numbers, however, is that there is probably a significant period of asymptomatic transmission, even in patients who are ill. Somewhere between 1 to 3 days prior, they are fully infectious. This was certainly frightening, as the initial report from Germany suggested asymptomatic transmission by a visiting business person from Wuhan. She later retracted her story, saying that she was sick when she did not appear to be, taking Tylenol and a number of other medications to reduce her fever. But if you look closer at the paper, it did demonstrate that the German contacts were able to transmit the infection within 1 to 2 days of being exposed to this person and several days prior to showing symptoms. The article was not ultimately retracted, and if you look at just the German part of the transmission, without regard to the visitor from Wuhan, it's clear that asymptomatic transmission was occurring in that particular stage. The mode of transmission is thought to be aerosolization, basically coughing, sneezing. Breathing should be relatively minimal, although it's still unclear how well it transmits in that situation. Surface contamination, there have been numerous studies showing that hard surfaces, it's recoverable up to a week. Soft surfaces, fabric, shorter periods of time. It is also excreted in ocular secretions, but primarily in patients who have COVID-19 related conjunctivitis. These patients are actively shedding virus from the conjunctiva and are clearly infectious. A recent Singaporean study, however, of asymptomatic, meaning ocularly asymptomatic patients with COVID-19 were unable to recover virus from the conjunctiva at the same time they were able to isolate and identify virus from oropharyngeal swabs. We also know effectively that there's a very high rate of health worker exposure and fatalities, especially in the epicenter in Wuhan, that ophthalmologists and ENT specialists were at significantly higher risk than general physicians, and that was attributed to the close proximity of the physicians to patients' faces during ophthalmic and ENT examination, as well as certain surgical procedures. And there have been multiple reports really demonstrating an increased risk for eye care professionals. The rate of infection among individuals is not known to vary, meaning that there doesn't appear to be a predilection for patients who have comorbidities or immunocompromised. However, the risk of complications of having the infection and becoming symptomatic appears to vary very significantly, and that those patients who have fatalities or ICU admissions or ventilator use significantly correlated with age, especially in those patients who are older, over the age of 80, but even in patients who are 60 and 70, it appears to be a significant increase as you get older in terms of the complications of the disease. The comorbidities that have been identified that also are associated include diabetes, hypertension, immunocompromised individuals, and pre-existing lung disease, especially asthma. Many of these patients can have significant complications and death from getting COVID-19. There have also been recent reports that patients who have COVID-19 who are intubated have a much more difficult time getting off of intubation and may have a higher morbidity rate. So in considering ophthalmic surgery, local anesthesia would probably be best if at all possible in the vast majority of patients. In the US, it has been identified that race is a significant factor in fatalities, being much higher than in other groups. It's unclear how much of that is due to existing comorbidities and healthcare disparities, but there appears to be some significant difference in the complications based on race. So given all of that, the principles that we've tried to put in place for management during the pandemic of ophthalmic care is, number one, obviously to protect patients, but also to treat ophthalmic disorders effectively. A very important component of this is to protect healthcare workers, not only because we don't want them to get sick, we also need to have the healthcare workers healthy enough with enough of them to provide ophthalmic care. And so all of the things that I'm going to describe here that we've done recently are really directed towards that. It really requires a complete rethinking of your current practice models in terms of where patients are seen, how they're seen, who they're seen by, in order to make this a streamlined process. And this is really only possible if clinic visits and surgical care administered is only to emergent and urgent patients with ophthalmic disease. The American Academy of Ophthalmology has a list that's applicable in the US. It may be slightly different depending on the country and patient population that you deal with, but volume clearly needs to be reduced during the pandemic, or you won't be able to put these processes in place, and eventually the system will break down. So starting with modifications to clinic flow, for us, thankfully, we have a single building that we could close all of the entrances to except for a single entrance. And I think having a controlled single point of entry into the facility is extremely important so you can control the flow of patients into the clinic. This should apply mainly to patients, but probably should also require a separate entrance for clinic staff as well as faculty to be screened separately. I think it's important that we put up signage so that unless absolutely necessary, only the patient will be admitted to the building, meaning that if they come with an entourage of family and children, that only the patient will be allowed into the facility and they will not be allowed to accompany the patient. This will dissuade people from bringing more people and also limit the number of exposures within the clinic. If any patient requires help, meaning ambulatory help or something of that nature, a single visitor may be allowed to bring them in, but really that should be an exception rather than a rule. Make also apparent on the signage out front that patients will not be seen for any routine follow-ups. If they're back for a year follow-up or a 6-month follow-up or something for glasses or something of that nature, unless it's an emergency in some other fashion, that those patients will need to come back at another time. You should also make available on your signage some sort of contact information, a website, email, telephone, where they can contact somebody if they're not sure whether they should be seen or whether their problem is urgent, that they can contact someone and let them know and discuss that with them with questions. Next most important is really screening. This should be staffed by ophthalmic technicians, front office staff, or nurses, or all of the above. The primary screening is really for general illness. If a patient shows any signs, obviously, of COVID-19, including shortness of breath, fever, etc., those patients need to be identified quickly. Those patients who also have just general symptoms of illness, or if they have ill contacts, or if they've had travel to places that are endemic, now including the United States, or they have signs of conjunctivitis, those patients need to be immediately determined whether or not that patient has an urgent or emergent ophthalmic problem. If they do, they should immediately be taken in, put into a separate isolation clinic away from the general clinic population, hopefully with transit from the entrance to that clinic not being exposed to any other patients. Patients may also be temperature screened. We do have that facility in at UIC where they are screening for temperature. And then if they don't have any signs of illness, then you also at that point need to determine their acuity level, meaning that how acute is their problem. If they have an urgent or emergent problem, they should be given entrance to the building, and we'll talk about that in just a moment. It would be helpful to have a resident, fellow, or even an attending physician who may not be on duty be available by telephone so the technicians at the front desk can call and find out if that patient does truly have an urgent and emergent problem based on initial screening history. Any patients who are denied entry should be recorded for later follow-up with their contact information so that once the pandemic is settled, they can be recalled for any routine appointments they need to make or non-urgent appointments that need to be made. Other modifications to clinic flow. You should have, again, as I mentioned earlier, a designated isolation clinic or clinic space that is away from the general population. All sick patients will immediately be given an individual room. They should not be taken to a front desk where they're registered and then a technician walking them into a room. They should be taken to a room, and we'll discuss that a little bit more later. The other thing you want to do is to eliminate waiting room space. So chairs should be eliminated or removed to allow so that chairs can be separated by at least 6 feet. There should be a limit of the volume of the number of patients being admitted to the building so that those waiting room spaces are not overwhelmed. You should also do your best to eliminate the need for a waiting room. So if patients come and are identified with urgent or emergent problems at the door, they should be given a specific appointment time to return so that a room will be available for them when they return. They won't have to be sitting around in a waiting room where cross-infection will be very common. So these can be given over the phone or some other contact information, or could be given at the main entrance when they first arrive. And then the biggest concept is one patient, one room, one technician, one doctor. Meaning when a patient comes, they get a room, they get one technician, and they get one doctor, and they're done. So as far as rooming is concerned, each patient is greeted by a technician, immediately placed in a room. They do an initial problem-focused workup. They leave the room. A physician can review that outside of the room. They can ask questions from the door. They're in protective gear. When they go in, they quickly take a look at the patient and they exit the room. They can either counsel the patient from the door, or they can give them a written set of instructions. The patient then exits the room and exits the clinic. Ancillary testing really should be done only if needed urgently. Um, eh, and this can be determined as in your local facility as to what constitutes that and what imaging capabilities you have. The clinic room then is fully disinfected before the next patient is placed in the room, um, and then the cycle starts over again. Modifications to the clinic room that can be helpful. Certainly, you want rooms with good airflow. Negative pressure rooms are ideal, but rare in an ophthalmology clinic. Good air exchange is important. If all else fails, a HEPA filter can be helpful as well. Um, there can be aerosolization that may remain in the room if the patient coughs or sneezes up to 15 minutes to 3 hours afterwards. So it's something that you should be aware of as a possibility. And that's why everybody really should be wearing personal protective gear, including either face shield, goggles, or and surgical masks as they enter each room. Our facility has instituted universal control masking, meaning that the patients are also placed in a surgical mask. I think that would help if those resources are available. As I mentioned, the slit lamp examination should be fairly short. We have designed full plexiglass breast shields, as you can see pictured on the right here, that are placed right behind the oculars so that it doesn't interfere with the view, but also reduces the chances of a cough or a sneeze being transmitted directly from the patient to the physician. There are commercial ones available that are fine. These can also be fashioned on the fly. There are a number of instructions on the internet how to do that. If you have the capability, a video examination would actually be very beneficial. There are slit lamp adapters that you can use for a smartphone, for example, or if you have imaging equipment. This should be something that should be in the isolation rooms so that you don't have to be as close to the patient as you need to be. And if you need consultation, then you can also take those photographs or that video of your slit lamp examination to a consultant without having to have them come into the room. So remote consultation is very helpful. You can also creatively use imaging if you have an Optos or other non-mydriatic cameras. If patients have an indication for dilation, if you can get by with a quick image rather than having the patient dilate, sit in your clinic for half an hour and then get up next to them looking at the retina, you may be able to get enough information from one of those imaging techniques without having to expose numerous people at close proximity to the patient. Staffing is also very important. We have to remember that our primary goal is really to treat patients, but it's also to protect healthcare workers. And in protecting healthcare workers, that will continue your ability to treat patients. If an entire clinic becomes infected, the clinic will effectively shut down and patients will not receive the care that they need. So the easiest way and probably best way to do that is really to split up your department into teams, perhaps without regard to what service they're on. We've sort of split our services into anterior and posterior segment and have really split the residents, front office staff, technicians, and fellows, as well as attending physicians, into vertical teams. And depending on the number of residents or fellows or front office staff you have, they all work together only. They do not speak or talk to other teams. They don't spend any significant time with them. We've had the luxury so far of being able to split our teams up into 2 or 3, meaning that we would have one team on for a full week and then off for another week, whereas the second team will come in and do the following week. If somebody on that team gets infected, depending on your local hospital rules, whether those patients have to go into isolation or quarantine, could put an entire team down. If you don't have teams, that person who is exposed or eventually becomes ill could infect the entire department. So it's very important to have this sort of vertical structure so that these teams are sequestered from each other, and any other learning or resident education or fellow education should be done remotely if at all possible through Zoom applications or WebEx or whatever is available. This will ensure that other teams will be able to continue providing patient care if one team gets infected. As far as hospital emergency department and offsite places, we've tried to limit or eliminate their exposure in other areas. Clearly, hospital ED will be areas where there will be high concentrations of COVID patients. If at all possible, we've asked the ED to send patients without other symptoms or other disease processes directly to the eye clinic or give them an appointment the following day, where they won't necessarily need to be screened for an urgent or emergent problem, but can come in once they're screened properly, or given an appointment time. This will limit the amount of exposure that your house staff, residents, fellows, etc., need to be in the hospital environment, where they could potentially become infected and bring that back to the department. We've also talked to other services and made clear to them that only emergent problems would be seen in consultation in the hospital, and that any routine or otherwise non-urgent matters would be given clinic appointments later, really to reduce the amount of exposure they have. Surgery is another area which is controversial. Here we've shut down all elective surgeries, and that includes a wide swath of anterior segment surgeries for sure. But those patients who have urgent or emergent cases because of the proximity to the nasopharynx, we do strongly recommend as much face protection as possible, N95, PAPRs if they're available and you can use them are fine, but it's difficult with a full face shield or PAPR using the microscope. Otherwise, universal precautions. If your institution has a facility to test patients prior to going to the operating room, that can be helpful. But generally, you should just practice universal precautions, as asymptomatic transmission, again, has been known to occur. And then finally, if you do have confirmed or possible COVID patients, as I mentioned earlier, the clinic flow needs to be very specific for these patients. Everyone needs to know what needs to be done with these patients. Clearly, if they're without an urgent or emergent ophthalmic problem, these patients should be either sent home or to the emergency department to handle their COVID symptoms. Their ocular symptoms or ophthalmic problems need to be handled later. If they are sick, but they do have an urgent or emergent ophthalmic problem, those patients should immediately be escorted from the front entrance to an isolation room. Yet everything should occur in that room. Registration and initial intake history can be taken over a telephone that it's in that room so that they don't need to have direct contact with that patient. And then full protective gear should be used, including gloves, face shield, N95 mask, and perhaps a gown when you enter to actually examine patient. Remember, conjunctivitis also qualifies, even though the asymptomatic patients without ocular symptoms aren't shedding virus. Those patients with conjunctivitis are, and that does make up some significant portion of the patients with COVID. It's not a large percentage, but that can sometimes be their initial symptom. And so those patients should be treated as if they have COVID as well with full gear. I will try to provide a guide which we've put together in graphic form of many of the things that I've talked about here. There are also things that may not be completely applicable, things like telehealth, if you have that facility available, can be used to at least see a portion of your patients during the time that you're shut down. The last thing I would tell you is that urgent and emergent has to do with time. Now, when we initially went into a lockdown here, we thought it would be at least 2 weeks. So yes, emergent problems needed to be taken care of, but urgent problems, things that could wait a month or so, we did put off, especially surgical, but also in clinic. At some point, however, you'll have to realize that this lockdown may be longer than 2 weeks. It may be a month or maybe 2 months, in which case you do not want those urgent problems becoming emergent problems. So once it's clear that these patients will not be able to be taken care of within a month, or that the lockdown won't be shut down within a month, those urgent patients now become patients that need to be treated now rather than 3 or 4 weeks from now when their problems become more emergent. It's a matter of philosophy and prediction, which is difficult in many cases, but will serve you well as you're thinking about how to integrate some of these patients back into your practice. Again, any questions, please let me know. Thank you very much for the opportunity. I hope this short presentation has been helpful in starting your processes to really combat the challenges of this viral pandemic. But really, above all, to my many, many, many cherished friends and colleagues there, my wishes are for you to stay safe and healthy, and I hope to see you again very, very soon. Take care.